All right, so with regards to the vertebral column, the first part of the vertebral column, looking at it from above downwards, it's the cervical vertebra, which are 7 in number. And we number them from the one that attaches to the occipital bone, being number 1, that's C1, to the one that will attach to thoracic vertebra, that would be C7, right? And there are things that distinguish cervical vertebra from other vertebra. Before we describe cervical vertebra, there are things that if you just see on a vertebra, it tells you already that this is a cervical vertebra. And they have what we call a foramen transversarium. I'll use an example here. They have a foramen transversarium within their transverse process. Right? This is what distinguishes cervical vertebra from all the other vertebra by just looking. Right? Yes, we are going to describe typical cervical vertebra, which is what most cervical vertebra look like, versus atypical cervical vertebra, which is what the other cervical vertebra will look like that are different. Right? But before we do that, let me draw a small cartoon for you guys, which I would want you to remember before we describe any vertebra. So, can you see the whiteboard that I've put up?
Yes.
Okay. So, we have what we call a vertebral body. Right. So, from the vertebral body, I'm going to use a mnemonic, which is PALP. P-A-L-P. The A means anterior. The P means posterior. Then the P, it's a part of the vertebra called a pedicle. Then the L, it's a part of a vertebra called the lamina. Right. So the P, the pedicle, is anterior. The first two words here. Pedicle is anterior. So extending from the body, maybe not this, let me use a different. So extending from the body, I'm going to have a pedicle. Okay, not this, okay. Let me just stick to this one. So extending from the body, I have a pedicle. So this is the front, this is anterior. Right. So extending from the body, I have what I call the pedicles. Because remember from the mnemonic PA, so pedicles are anterior. Right. Then going posteriorly, it's now LP. So lamina are posterior. The lamina are like this. Right. So don't mind the sketchy drawing. That's the way I draw things. So where a pedicle, that's a pedicle, that's a lamina. Where a pedicle meets a lamina, I create a transverse process. The one that I'm labeling T. Right? So where pedicle meets lamina, I'm going to have a transverse process. Where the two lamina meet in this region, I create a spinous process. This is the general structure of a vertebra. The space that is left between the body and these projections. This space that I'm putting, that I'm writing within now, this is what we call the vertebral canal. That's where the spinal cord will be housed within. Right? And that vertebral canal has a different shape depending on the region again. So when we do the regions, when we say maybe cervical vertebra, we're going to see that the shape for that vertebral canal is going to be large, number one. Number two, it's going to be triangular. Versus, say, the space in the thoracic region, which is going to be small and circular. And so there are going to be differences between vertebra. But this what I've drawn for you, this is the basic outline of a general vertebra. Right. So I'm sure you can now see my screen backup. Confirm?
Yes.
Great. So we have cervical vertebra, like I was saying. And cervical vertebra are 7 in number. And to make it easy for you, you first describe what we call a typical vertebra. That vertebra that has all the characteristics that are ascribed to a certain lineage of vertebra. And that's going to be C3, C4, C5, C6. Meaning to say that the first, the second, and the seventh, they are not typical. So why is it easy to do that? The moment you know what most of the vertebra look like, what's left is to now say, so if C1 is not typical, what is different about C1? What is different about C2? What is different about C7? Makes your life really, really easy. So I'm going to look for one typical cervical vertebra, which we can use to describe. This is C5. So we can use C5 to describe a typical cervical vertebra. And look at it closely. This is the body, right? I showed you the pedicles. These are the pedicles. These are the lamina. Remember I said where two lamina meet, you create a spinous process. Still on this spinous process, it is only in the cervical region where you see a bifid spinous process, one that divides into two. All the other spinous processes for all the other vertebra, they are not divided. Right? So it's only in the cervical region where you have a bifid spinous process. Right? This is going to be the body. As you can see, the body is small. It's not as large as you'd expect. Right? And it looks broader, moving from this side to that side. So it is wider when you're looking at a side-to-side arrangement as compared to the anterior-posterior diameter. So there's a larger diameter going sideways compared to a diameter going anterior-posterior. Right. Then this is the vertebral foramen that I was trying to describe for you guys. And this vertebral foramen, already you can tell that it's triangular in shape there. And it's large. So I'll give you guys a reason why this is large or what you can use to remember. So think about the spinal cord. Spinal cord, I said it's within that vertebral foramen. And in which region is the spinal cord largest? Spinal cord, it's largest in the cervical region. Right. Why? In the cervical region, that's where you have all the fibers, either fibers coming from the brain or fibers coming from the periphery. They're all bundled up in that cervical region. as well as we have cervical enlargements for the spinal cord in that region. You're thinking about brachial plexus for the upper limbs. You're thinking about cervical plexus for the neck. Right? So those are a whole bunch of reasons why this vertebral foramen is going to be largest in the cervical region. When we do the lumbar, we're going to find that the lumbar vertebral foramen is also going to be somewhat triangular in shape and a bit large as well, but it's not as large as the cervical one. Right? For the lumbar one, you're going to see the reason will be for the lumbar enlargement of the spinal cord, which is responsible for the lower limbs innervation. So we're going to have a lumbar plexus and a sacral plexus when we describe limb innervation with regards to the lower limb. Right. So this is your vertebral foramen, quite large, and it's triangular, right? Now bring your attention to these smaller pictures here. Okay. So remember, vertebra attach. For example, if I have C5, for example, this is the one that I'm referring to. C5 is going to attach to C4 above. No, yeah, C4 above, then C6 below. Right. That means there have to be articular facets. That means we have superior articular facets, then we have inferior articular facets. Right. For there to be a normal articulation. So we need to know the shape of these articular facets. Back in the day, when I was still doing my anatomy for MBCHB, there used to be this lady who taught us that the moment you realize that if you say superior, this is an example before I describe this. If you say that superior faces upwards and lateral, obviously inferior will face in the opposite direction. It will face downward and medial. That means you don't need to go cream the superior, then the inferior. Best case scenario, if you know the superior, the inferior one will be the opposite. If you're smart enough, you can then know everything. Right? But the first port of call is for you to remember things, right? So the superior articular facets, they face upwards and backwards. So superior facets, they face upwards and backward. That means the inferior, you know. If this is upward, this is going to be downwards. If this is backwards, this is going to be forward. So inferior articular facet, this one, for cervical vertebra, it faces downwards and forwards. Then you're good. Right. Then I mentioned this unique feature for cervical vertebra, that they have a transverse process with a hole. That's what we call the foramen transversarium. What do I find in this foramen transversarium? Whenever I see a hole in anatomy, something is definitely going to be passing through. More likely going to be an artery, a vein, or a nerve. In this case, these foramen transversarium, they allow passage of the vertebral artery and the vertebral vein. One of the reasons why C7 is going to be atypical is that its foramen transversarium is going to be very, very small, such that it will not allow passage of both the artery and the vein at once. Only one thing will pass through. So that will be one of the reasons why C7 is going to be atypical. I'll get to C7 when I describe it alone, since it's an atypical vertebra. Right. So this is a unique feature for cervical vertebra. they have a foramen transversarium. This foramen transversarium allows passage of the vertebral vessels. So there's going to be a vertebral vein, there's going to be a vertebral artery. When you do your thoracic anatomy, those vertebral vessels, or the artery in particular, it comes from the first part of the subclavian artery. You will notice that when you do your thorax. Right. Then I told you about the spine. Only cervical vertebral spine will be short and bifid. Right. Only cervical vertebra have a bifid spinous process. Bi means two, bifurcate to two. Only that for the cervical region will be divided into two. Right. Then having done this, you can now describe the atypical ones. Right. So the atypical vertebra, we say there's C1, C2, then C7. C1 and C2 have special names ascribed to them. C1 is what we call the atlas. I'm sure you've done geography before, right? You know the reason. I'll tell you. C2 is the axis because it's the axis of this rotation. Right. So C1 is the atlas, which happens to be this one. Right. Why is it called C1? Because it supports the globe of the head. Right. So even if you go back to what you call this, Greek mythology, whatever, right? That's where you hear these things about a Greek god called Atlas, who supported the globe, what, for like the whole earth. Remember, the earth is like a globe, right? So whatever the god put it on their shoulder and they supported the earth, whatever, and they, those funny Greek stories. That's where the name Atlas came from. So Atlas is this, right? So there are many reasons why C1 will be atypical. But for you to know that, you need to be able to describe a typical cervical vertebra, what we have just described. So, one, let's look at the shape. There is no body, there is no spinous process. This looks like a signet ring. I'm sure the ladies, they know the fashion signet rings. Signet rings are rings where you have one side, for example, this end, the anterior side. You have a ring that side that is shorter compared to the other one at the back there. So there's a larger posterior arc and a smaller anterior arc. I will not bore you guys with much of the specifics of how this vertebra looks because it's not as simple as it looks. But I'm going to tell you how it's different from the other typical cervical vertebra. So I've shown you the shape. It's ring shaped. There's no body. It has no spinous process. Instead, it is what we call lateral masses, these ones. So it is a lateral mass and a lateral mass on that end. So there's a right lateral mass and a left lateral mass, but it retains the transverse process at the end there. So it does have a transverse process, meaning there is still the foramen transversarium, that one. And this foramen transversarium will actually be the one that allows for passage of the vertebral artery and the vertebral vein. Right. So this is the anterior arc, posterior arc, and each arc has a tubercle. So there's anterior tubercle on the anterior arc, posterior tubercle there. Right. Then in terms of size, remember I said posterior arc is larger than anterior arc here. Right. So this posterior arc will actually make the greater part of your ring. It's about 2/5 of the ring. Right. The anterior arc is about 1/5 of the ring. Right. Then I won't bore you with other details about this. We can do a whole lecture on C1. There's a whole lot of things. Then C2 is also atypical. This one, I think you can see from its shape as well. It's called the axis. Let's use this one. So axis, can you see it is this funny process here, which is not there on the other cervical vertebra. This funny process is what we call the DENS, DENS. Phylogenetically or through evolution, the DENS is believed to be the displaced body of C1. Remember I said C1 does not have a body. That body is believed to be there on C2 as the DENS. Right. So C2 is atypical because of this funny feature that it has. Right. So others prefer to call it the odontoid process labeled here. It's still the same thing. To say dense or odontoid process, it's still the same language. Right. Then there is also the transverse processes. But something that is unique about C2, something that I haven't told you about cervical vertebra. I'll get back to this picture for a moment. A typical cervical vertebra. The transverse processes of a typical cervical vertebra have what we call tubercles, an anterior tubercle and a posterior tubercle. Why is this important? When you guys did your head and neck, you described the common carotids going up. You say that you can actually roll the common carotid against the anterior tubercle of C6, which you called Chassagne-Neck's tubercle. These are the tubercles that we're being referred to. So just know that a cervical vertebra has tubercles. The tubercles, there is an anterior tubercle, then there's a posterior tubercle. Right. However, the transverse process for C2, another reason that makes it atypical, the transverse process of C2 lacks the anterior tubercle. Right. I'm trying to give you ways in which these vertebrae differ from the other typical cervical vertebra. Then, of course, the articular facets for C2 and C1, they are different from the ones that I described, where we said each vertebra articulates the vertebra above and the vertebra below, right? But for C2 and C1, they're different. Right? These ones, it may be a bit hard to remember, but you guys, I trust you have done head and neck. And you remember the occipital bone had occipital condyles. And you saw where the condyles were facing. So let's go back to C1. This is C1. These are the superior articular facets that articulate with the occipital condyles. Right? They're described as being elongated and concave. Right? Then the inferior ones are just described as being almost circular. These are elongated. Right? Then I always struggle finding a picture of C7. This preferred atlas of mine doesn't have a picture of C7, but I'll tell you what C7 looks like. The spinous process of C7 is long compared to this, where I said a typical cervical vertebra should have a short spinous process. That for C7 is long, and it is not bifid. Because remember I said a typical cervical vertebra should have a short bifid spinous process. That for C7 is not going to be bifid, and it's long. Why is it long? There's a rule that I taught myself growing up that for me not to forget, the last vertebra in a line resembles the next line. For example, the last vertebra in the cervical region will resemble the thoracic region, such that When I describe thoracic vertebra to you, you're going to see that they have a very long spinous process. So C7 being the last in the cervical region, it's going to resemble the next line. That's going to be characterized by a long spinous process. When I do the lumbosacral region, we're going to talk about sacralization and lumbarization, where a particular vertebra in a certain line takes the characteristics of the line above it or below it, right? Then the spinous process for C7 also lacks an anterior tubercle, just like C2. And when I started, I said one of the reasons why C7 is atypical is because it has a very small spinous not spinous, but a very small foramen transversarium. This hole, when you look at it on C7, it's going to be very small, and it won't transmit both the vertebral artery and the vertebral vein. It will only transmit the vertebral vein. Right. Then clinicals that are associated with cervical vertebra. I talked about the carotid tubercle, which is the anterior tubercle of what do we call this? C6, where you can actually compress or roll the common carotid against it. Right. Then there's Klippel-Feil sequence. Klippel-Feil sequence, this is an embryological condition where cervical vertebra are fused. Not cervical, okay, any vertebra are fused, but it favors the cervical region, commonly between C5, C6, C7. So you are born with vertebra that are fused. Right. Then there's what we call Hangman's fracture and Jefferson's fracture. To go into the mechanics of that, that's a bit of pathology, but just remember that Jefferson's fracture, it's a fracture of C1 versus Hangman's fracture, which is a fracture of C2. To be specific, you'd have had what we call a bilateral fracture of the pars interarticularis, but don't worry about that. Just know that Hangman's fracture C2, Jefferson's fracture C1. The reason why it's called Hangman's fracture, one would assume that that's where the fracture happens when you are hanged. But it's both true and false. This is when you are hanged professionally by a professional, not when you just go below your mother's tree and you hang yourself. Right? But yes, that's what happens. So when I looked at your course outline, there were joints that were listed. Like I think it said know the joints and the movements. So please remember this. I'll use a very funny example that you'll never forget. If a girl is approached, the first thing they'll say is yes, right? If they like the person. Then down the line, they'll see that the person is rubbish, then they'll say no. Right? Great. So where is this fitting in? The joint between C1 and the cranium, or basically the occipital bone, which we call the atlanto-occipital. Atlanto because of the atlas, occipital because of the occiput. That's where there's the movement of nodding. This is flexion and extension. So that's the joint between C1 and the occipital bone. The next thing they do is to say no. They say that you are rubbish. So this is now the joint between C1 and C2. This is what we call the atlanto-axial joint. It's now the joint between the atlas C1 and the axis C2. I know there is more to these joints. There is ligaments, there is whatsoever. But to make your life very easy, that's where you start. Just know the movement of the joint first. Right. So atlanto-occipital joints, they are synovial. Atlantoaxial, synovial as well. But atlantoaxial is a combination of 3 joints. It's not just one joint. So I like to introduce things in bits and pieces. You don't just tell people that there's this joint, this joint, and this joint, then they lose the plot. So you give it in bits and pieces. So they are both synovial joints, fair enough. Now I've told you that atlantoaxial is made up of 3 joints. Right. Then ligaments. Important ligaments for the atlantoaxial. There's a ligament called the ala. There's a ligament called the apical. Apical ligament, then ala ligament. So like for your ala ligament and your apical ligament, you're going to have them being unique to that joint, right? So they're only going to be there for your atlantoaxial joint, right? That's going to be C1 and C2, right? So